Dr. Sandeep?
Yes, ma'am.
Yes, I think now good enough number have joined. I'll just introduce you and then we can start. So, hello everyone. And so this is our last session of our MRA teaching sessions in the regular sessions. After that, as you all have requested some special topics, we will chalk them out and then prepare a schedule for that. So today's speaker is Dr. Sandeep Yadav, who has finished his DNB from the prestigious Hinduja Hospital, Mumbai, and he's a consultant at Hinduja Hospital. He's going to speak about gout. Now, gout is a very misdiagnosed, overdiagnosed, underdiagnosed disease. So even if you see in your OPD, many of the patients are diagnosed as gout, and even maybe 10% of them really have gout, and others have just been diagnosed on the basis of a high uric acid level. So Dr. Sandeep will clear some of your doubts about it, and then later you can ask him whatever questions or doubts you have. So go on to Dr. Sandeep.
I'm audible?
Yes, Sandeep, you're audible.
Yeah. So, good morning, everybody. So, when talking about gout, I'll take you through certain basic aspects first, and then I will go on to move and discuss the clinical aspect, some case scenarios, what is gout, what is not gout, and slowly let me take you move forward. So, first, I'll just introduce the basic concept of gout. So, you can clearly see these are the gout crystals which are seen under the electron microscope. See, they are needle-shaped crystal. They are stacked upon one upon other, and this is how you can see the gout crystal inside the microscope with a compensator attached here. So basically, when you look at gout, so just which is a single sentence which can describe gout as a disease. So for I think pathology is the soul of medicine, and understanding the pathology is most important part. So I first want to concentrate on etiology. When I look into the etiology of any disease and when I talk about gout, I want it to be fitting in one of these things. It may be, what is the etiology of gout? Whether it is genetic, infection, neoplastic, environmental, lifestyle, inflammatory. So when I look at gout, it's an overlap of more than one thing. It's basically environmental factor. It may be lifestyle and metabolic factor, inflammatory, and all three this together lead to formation of something called as crystallopathy. So basically, gout is crystal-induced inflammation, and this crystal-induced inflammation happens when the patient has genetic tendency, when the patient has hyperuricemia, and this crystal have an immune and auto-inflammatory response, and which leads to the pathology. So what the single sentence to introduce to gout is basically crystal-induced immune-mediated disease with predominant musculoskeletal manifestation. Single sentence which can describe gout. So the other important question is why we should know about gout. So the most important thing is gout is one of the most common form of inflammatory arthritis that affects adults. If you look at diabetes, the diabetes range varies between 8 to 18%. If you look about osteoarthritis, it is 10%, but it's mostly non-inflammatory. If you look at rheumatoid arthritis, the epidemiological study have shown 0.5% maybe around. If you look at American data, it may be around about 1%, 1.5%, something like that. Looking at that, the prevalence of gout maybe like 6 to 7% or more than that. We don't have any epidemiological study from India. And the important thing is it is increasing. The prevalence of gout is increasing. There is increasing trend, and this has happened because of the shift to the Western lifestyle has shifted our tendency to have hyperuricemia. All these things, obesity, metabolic syndrome, increasing alcohol consumption and soft drinks, all this has contributed to the hyperuricemia and definitely have contributed to the increased prevalence of gout. If we can clearly see the Western lifestyle, which is adopted in the world in this map, that's the US, North America and Australia, have more amount of hyperuricemia and more prevalence of gout, and slowly goes on decreasing towards the other countries. And in India, it is very low. There may be also lack of epidemiological data from India. And the third, the most important thing, why we should know gout is one of the most often mismanaged condition. Any hyperuricemia is treated as a gout. When you sit in the OPD, people with range 6.5, 7.5, 7.1 has been treated when started on hypouricemic drug. Plus, they have a lot of misconceptions stopping stopping this foodstuff, so taking that medication. So I think knowing about gout will clear all that misconception and prevent misdiagnosis and overtreatment. And the fourth important concept, which I think we should know gout is the implication of gout, which is beyond joints. So gout is a metabolic disease. and joint manifestations are only one part of his manifestation. So I think manifestation of gout beyond the joint should also be known as a treating physician and clinician. So I'll try to cover my topic under these 10 headings. First, I'll talk about some uric acid metabolism, uric acid pool, because that is what is required when you give any generic advice as far as diet and other medications are concerned. Then I will try to say how uric acid to hyperuricemia to gout. Then I'll talk about pathology of gout. Then I tell why not every hyperuricemia is gout. And then I'll take you through the natural history of gout. Then I give three cases on clinical scenario of what is gout, three cases of clinical scenario what is not gout, and then short investigation things which is important, and small management strategies, and just a single slide on gout beyond joints. So the initial few slides I will carry you through uric acid to hyperuricemia and gout, how this uric acid leads to hyperuricemia and this hyperuricemia leads to the gout. So for this, the first thing we should understand is the uric acid. So where does uric acid stand in our present metabolism? So when we look at our metabolic waste products, we have carbon dioxide, which goes through the respiratory system, and the nitrogenous waste product, salt and acid load, both go through the kidney. And when we talk about nitrogenous waste product, we have urea and uric acid. So where that this uric acid in our metabolic waste product conduct come from? The first and important thing is total number of cells. All the cells have the DNA and RNAs. All the DNAs have a GMP and AMP, adenosine monophosphate and guanosine monophosphate. Plus the energy metabolism, any consumption of the ATP, any strain, any fever, any increase the consumption of the ATP, and everything produces adenosine, inosine, and everything goes to the common pathway to form xanthine, and this is secreted as uric acid. So we can assume here that uric acid is a part of nitrogenous waste product metabolism in the body, especially the purine metabolism. So we go to the next part. So what is the source of purine in our present body? So we'll first go to every cell in the body has DNA and thus a nucleic acid. So contribute to the purine in the body. Every cell in the body has ATP, AMP, and GMP. So it will contribute to the purines in the body. All the purines from the diet, including the red meat, soft drinks, beer, everything has purine in the diet, and that may contribute to the purine in the body content of the purine pod. And synthesized in the body, the salvage pathway, which we use for our DNA synthesis, is where we have synthesis of purines in the body, which contribute less overall things. So all these purines in the body is excreted as uric acid, out of which 2/3 is secreted through the kidney and 1/3 is secreted through GIT tract. So if you want to understand how the so this was uric acid, we now go to hyperuricemia. So just based on this concept, let's try to understand how does hyperuricemia happen and how does it lead to gout. So traditional classification of hyperuricemia is first thing. It may be based on overproduction, in which may be a high turnover. Patient may have malignancies, patient may have very high purine rich diet, patient may have genetic deficiency and less enhanced syndrome. All these things may lead to overproduction of purines and overproduction, and that may lead to hyperuricemia. The second way in which the hyperuricemia happens is due to undersecretion. And this was the cause of increased body weight, proliferative disorder, abdominitis, all these things lead to overproduction. And the other things like decreased renal secretion, CKD, ESRD, diuretics, the cyclosporin with decreased kidney filtration, pyrazinamide. All these things lead to decreased renal secretion of uric acid, and all this leads to hyperuricemia. So just to make it clear that 90% of the hyperuricemia is due to decreased renal secretion, and very few, only 10% are due to the overproduction. So we know the hyperuricemia, most common cause is decreased secretion. So I told you about uric acid, I told you about hyperuricemia, overproducer and undersecretors, and finally I'll try to take a second slide where I want to understand what is body urate pool. So what happens, there is certain amount of uric acid level in the body, there is certain amount of extracellular content, and when the body exceeds this extracellular content, the extra uric acid get deposited in the body. So at any time, new synthesis, purines from the diet, everything have a uric acid, extracellular uric acid pool of 1200 milligrams. Okay, out of which 600 is probably secreted in the urine every day, and 200 is and this 1200 milligram of uric acid pool is maintained. So if uric acid pool increases, the secretion of urine and the intestine both increases, and body tries to maintain the uric acid pool. But when it happens over a long period of time, it reaches saturation level and get deposited. Basically, You should know. So anything. So this uric acid pool is important because when you try to understand 24-hour urine secretion to understand what is the cause of hyperuricemia. Suppose we think it is under secreted. So probably when it is under secreted, the 24-hour urine secretion will be less than 800. If suppose the patient is the overproducer of uric acid, so we will try to see it in a way that uric acid secretion is even above 800, above 1200, and still the patient has hyperuricemia. So just imagine you had so imagine a solution in which you are trying to put a salt and try to dissolve. Suppose this is like 5 liter of 5 liter of blood in your body, and you try to saturate it with uric acid, extra uric acid here. At certain point of time, it will keep dissolving, keep dissolving, keep dissolving. But at a certain point of time, the uric acid level increases the saturation point. The uric acid crystal, the uric acid deposits as a crystal in the body. So same way, I'll just try to take this slide where the gout pathology. So here is the body extracellular pool. Here we have no super saturated or pool. This body extracellular pool is in unison with the serum uric acid level, which stays between 4 to 7 milligram. And anything above this rise in the extracellular body pool of 200 milligram will increase the serum uric acid level, and it is also over the period of time when get over the saturation value will deposit it basically into 3 to 4 things. So deposition of body tissue in skin, synovium. If you see here, it get deposited in the synovium, it get deposited in the tendon here. It get deposited in the other soft tissues, and it may also get deposited in renal uh, glomeruli, and all these things may lead to gout. So basically, gout is a pathology in which monosodium urate crystals get deposited and will lead to this. So looking at one more slide here. So hyperuricemia, and try to tell you here why hyperuricemia uh, is not always lead to gout. So if you see that hyperuricemia is a single word which will describe hyperuricemia. It is essential but not sufficient for what. And why this happens? Because approximately two-thirds of the patient with the persistent hyperuricemia never develops gout. So just to take it another example, another way to look at it, only 5% of the patient with the serum uric acid level 7 develop gout over the period of 5 years. So suppose the patient has 10 milligram 10 uric acid level of 10 milligram person, he has 30% chances of developing attack of gout over the period of 5 years. If it is 7, it's only 0.6%. So hyperuricemia is essential, not sufficient for gout. And now this hyperuricemia will lead to crystallization and deposition of joint as a monosodium urate crystal. But we should know that, but even at a saturation point of 6.8 milligram per DL and at temperature 37 milligram, crystallization requires many days. So there is some contribution of the immunity here. There should be coating of these crystals with the IgG, IgM crystal. So here comes the immunity in the picture. This crystal get coated with IgG, IgM, then they are engulfed by the then these crystals which are coated are then engulfed by the macrophages, and two kind of reactions happen. The first is the acute inflammatory response, which leads to acute attack of gout. And over the period of time, this engulfment of the macrophages will give a chronic granulomatous inflammatory response, which will on the long term lead to tophaceous gout. So now I told you about the metabolism pathology, how the uric acid hyperuricemia has lead due to the deposition of uric acid crystal through the macrophages, and it has lead to gout. So the important thing I have to understand is what is the natural history of gout, because without understanding the natural history of gout, we don't know whether we are treating the patient or not. So just a single slide on how hyperuricemia of gout, natural history of gout. So patient has asymptomatic uricemia. This asymptomatic hyperuricemia over the period of 1 to 15 years will lead to deposition of monosodium urate crystals over the period of multiple joint tissues, and other joint, and finally it will progress to symptomatic gout. So just a few clinical features on symptomatic gout. When the symptomatic gout comes, it comes as a single attack. So there are few characteristics. So the most important thing, when the gout starts in the initial phase, when the attacks are mostly one joint at a time, it is sudden onset. Sudden onset, there is swelling, there is excruciating pain, there may be superficial redness, and the attacks are self-limiting. The attack lasts around 7 to 14 days. If the attack lasts for more than 2 weeks, we should always doubt our diagnosis, definitely in monoarticular gout. And there may be a precipitating trigger factor, maybe binge alcohol, drinking red meat, seafood. So there will always be history. And if you ask the history clearly, the two intervening period between the two attacks of gout will be normal. So this intermittent attack of gout, probably the patient may initially have the gout attack, which may be only once or twice a year, and slowly over the period of time, when the uric acid crystal load increases, the attack may become more frequent, around 1 or 2 attacks a month. And this frequency of attack increases, and finally the patient may land up with the chronic propitious gout, in which the body initially, which was mounting acute response, starts to mount a chronic granulomatous response, and with the deposition of gout crystals with granuloma formations here, granulomatous reaction formation, which leads to deformity of the joints and bone erosions. So this is how natural history of gout progresses from asymptomatic to intermittent attack to chronic trophic gout, polyarticular gout. So the next important thing, I'll just give you some clinical cases, clinical scenarios where how does the gout really present in the OPD and IPD setup. And there are three main forms in which. So this is the classical case, first case. So this is 45-year male who has a sudden onset pain. He has redness and swelling of the base of the first MTP, which was sudden in onset in 2 days. He doesn't give any history of trauma. He doesn't give any history of fever. And if you take the detail, he say that he has this similar attack since last 8 years. The attack have been very intermittent, and it has always been a one joint at a time. There may be alternating legs. It may be ankle joint, dorsum of the foot. And he says that most of the time he pops in 1 or 2 painkillers, and the day attack lasts for around 4 to 5 days. And he will, if you ask more clearly, he will also say the attack may be precipitated by a binge drinking and other things. And he may also tell you, he may also give a history that the number of attack has increased so many years. So when I look at this, I want you to approach this as acute monoarthritis. So you just evaluate him and you find the uric acid level at 8.3. But at this point of time, I'll take this opportunity to tell you how do you approach this monoarticular arthritis. So when I look at monoarticular arthritis, I am not going to discuss about the chronic monoarticular arthritis, but when I'm looking at monoarticular arthritis, which is acute in nature, which has superficial redness. So my differential just comes down to these four things. This attack may be attack of gout. It may be attack of palindromic rheumatism. It may be infection. It may be reactive arthritis with SPA. I already have the history of fever and trauma. If trauma present, it may be acute passing by event. If there is fever, maybe look into more into infection. But when I ask a more detailed history of monoarticular gout, are the attack intermittent and self-resolving? When it comes to the reactive arthritis, it lasts more than 1 month, 3 months, 4 months. But when I ask whether it is self-resolving and intermittent, there are only two differentials left. Either it is palindromic rheumatism, either it is gout or crystallopathy, CPPD, BCP, and other crystallopathies. So when I see a classical history of migratory upper limb pain, which is predominant and the antibody is greater than 54%, I think it is more of a palindromic rheumatism. But when I get a clear-cut history of precipitating event, may have a history of renal stones, I think it is more of a gout. So, but whenever in doubt, whenever any of you have doubt whether this is infection, whether this is trauma, whether this is palindromic rheumatism, whether it's crystallopathy, aspirate and see. Whenever you have doubt in monoarticular acute arthritis, you aspirate and see. So coming to the case again, in this case, we get a clear-cut history. History is diagnostic itself. We get intermittent attack. We don't need any other differential, even if the uric acid levels are normal in this scenario. Because sometimes you will find some patient uric acid level normal, but he still gets the attack of gout. In that scenario, I think I'll come to that part why the uric acid level may be normal during the attack. I'll cover in different slide. But this is classical history in which you should never miss. The second case may be probably mainly IPD reference. When the patient here comes, 55-year male, he may be admitted for bypass surgery, and he has a 3 days post-operative period. He presents with sudden onset left knee pain and swelling, which has superficial redness. I can clearly see here there is right knee swollen here with a superficial redness. It look more swollen, it look more like infection, and you find out that uric acid level is 7.9. In this scenario, we don't have a choice. But if it is only one joint, infection should always be ruled out. So we did the aspiration of the synovial joint, and this is what we found. You can clearly see here, these are the uric acid crystals. Just imagine a small amount of pain and just you drop you on the floors. This is how they'll stack up with each other. This, and I will explain you about this is a classical picture when you see inside the compensator microscope. And I have few slides on that also. Suppose this is a microscope, this is normal microscope. All the light going through this compensator microscope is non-polarized. And for see the gout crystal have a specific property. The gout crystal have specific refractive index which is changes with the angle of incident light. So we use this property of this crystal property to just identify which kind of crystal we are seeing inside the microscope. And we take the advantage of this by references property of this gout crystal to basically find out what kind of crystal it is. And one of the most important diagnostic thing we look inside the microscope. So these are the compensator we attached here. And this is how the compensator works. The light which was going in multiple plane has been now just channelized to single plane and just transmitted through the crystal. And in this way, if you polarize the light, either it may go parallel to the crystal, or it may go perpendicular to the crystal. So I have single slide, single video for you where I will try to give you a good idea how this macrophages will, how the macrophages are basically trying to, this is the macrophage, this is the gout crystal, and this macrophage is engulfing this gout crystal. And you can clearly see that macrophage is engulfing the gout crystal. Now we have switched to polarized microscope. Earlier microscope was not polarized microscope. Now we have switched to polarized microscope. And now see. See. Now this is basically the axis of the compensator, whether it is parallel, whether it's perpendicular. So when it is perpendicular, it looks blue. When it is parallel, it looks yellow. This is a simple thing. I'll give you a mnemonic where you remember in this side which kind of. So now the crystal is turning in the direction of the compensator and it's turning yellow. It's basically a property of the crystal. They have nothing to do with anything else. But you can clearly see the needle-shaped crystal here. And this crystal shows orange-yellow color when the axes are parallel. This is negative birefringence. This is another crystal which is perpendicular to the direction and it shows blue color. Just a single slide. We move on to the slides again. Okay, so just to imagine when the compensator light is parallel, we see yellow color crystal. This simple mnemonic which is remember, and when it's perpendicular, it is blue. So we don't have to go into much in the depth of this, but just to say why is just okay. So just to show the crystals again how they look into the microscope. When they are parallel to the compensator, they look yellow, and when they are perpendicular, they look blue. So I told you the first case scenario, how does the gout present? Typically a family history of gout precipitating event. The second scenario was basically an event in which after 2 days of major surgery or stress, patient present with the attack of gout, you aspirate, we get the aspirate crystal. It may also start after the start of the drugs, which actually lower or increase the uric acid level. Basically diuretic increase the uric acid level, load of aspirate during the cardiovascular surgery may increase the uric acid level and may precipitate gout. Sometimes the patient after starting anti-tubercular paracetamol may alter the secretion of uric acid crystal and may precipitate an attack of gout. Suppose the patient is admitted for chemotherapy, patient is admitted for lymphoma, patient undergo rituximab treatment, R-CHOP regime. All these things will increase the acute uric acid level in the body, will lead to hyperuricemia, and all these things can present with a precipitation of gout attack. And the third scenario, this is all. And the other important point I want to note here is the gout rarely presents in women before the menopause. What happens? Estrogen is the uricosuric agent. So if I am making a diagnosis of gout in the woman which is premenopausal, 9 out of 10 times I may be wrong. Until unless the patient has been started on anti-tubercular drug, patient is on chemotherapy, patient is on cyclosporine, or patient has some other major other risk factors. 9 out of 10 times I'm wrong, we can make a diagnosis of gout in the patient, premenopausal woman. So we just go on to next, the third scenario. The third scenario is the patient has been having this acute attack, but he stays in the periphery, he had not got medical attention. And finally, over a period of time, the acute inflammatory reaction has matured in the chronic granulomatous reaction and multiple uric acid crystal deposit in the body, in the PIPs, tendons, joints. And finally, this is how they destroy the joints. They don't destroy the joint space. See here, the joint space is normal. It's basically trying to, just imagine, it is hanging edge. It is trying to crawl from outside inside. It is crawling in. So it's like eating up from outside. It's the bone part which is eaten up more than the joints. So we'll get a typical hanging large erosions in the joints. When we look about RA, we have marginal erosion, joint space reduction, other things. So this is a third scenario in which the gout present. The first was acute intermittent attack, second was after surgery, and third was as a proficiency gout. And the site of proficiency deposition may be anywhere. We may have earlobe shouldn't be missed during the clinical examination of the gout part, elbow shouldn't be missed, sclera sometimes we examine. So this was the three clinical scenarios when I explained you how the gout present. And the other thing is what is not gout. We should know what is not gout because there is a lot of myths surrounding gout treatment. Every hyperuricemia, every non-specific joint pain has been treated as gout. So the first clinical scenario, what is not gout? Suppose the patient comes with you and patient presents a polyarticular joint pain and swelling, which has been persistent of more than 2 to 4 weeks. So in this scenario, I should clearly see, I know that gout is self-limiting disease. It should get better in 3 to 7 or maximum 14 days. But the patient has persistent joint pain and swelling which is lasting 4 to 12 weeks. I should doubt my diagnosis. I shouldn't make a diagnosis of gout until I'm suspecting polyarticular gout. And the other thing is gout is a gout in the so when gout is polyarticular, there will be signs of tophi deposition present in multiple tendons and other joints. So if I'm making a diagnosis of a joint pain and swelling which is polyarticular lasting more than 4 weeks without any chronic signs of joint tophi and other things, I may be hardly correct. So other thing is gout involve both articular and extra articular tissue. And disease like RA is only associated with synovitis and not associated with inflammation or periarticular issue. So just to look at this, so when you look at the rheumatoid arthritis typically affect the synovium. The inflammation doesn't go outside the synovium. It is typically confined here. But when you look at other diseases like gout, which are crystallopathy, there is periarticular inflammation. There may be superficial redness. This is the same thing which happens in palindromic rheumatism. This may same thing happen in gout, where there is post-inflammatory hyperpigmentation. So in RA, only joint space is involved, but in other scenarios, periarticular joint space is also involved. And this is what differentiates gout from other diseases. And there are only 5 differential for acute monoarthritis with superficial redness. I told you earlier. It may be trauma, it may be infection, in which the history and clinical examination may be helpful. Crystal induced arthropathy, mainly gout, CPT, because crystal induced arthropathy comes more of an autoinflammatory than an autoimmune disease. And other things I already told you, reactive arthritis. Reactive arthritis will be like chronic, more lasting for more than 4 weeks or something like that. And palindromic rheumatism may have anti-CCP positive and more upper joint involvement. So the first case, polyarticular joint pain and swelling, persistent for more than 4 weeks. This is less likely gout. So this shouldn't be missed. The second case scenario is patient has persistent joint and non-joint area pain with mildly elevated uric acid level. So you look at this scenario, they took a clinical physician and other thing, they find that uric acid level is between 7 to 8. And the patient may be on febuxostat for probably say 2 to 3 months. They have been told that all these joint pains and everything have been due to high uric acid level. So I'll again clearly mention this. Gout is a crystallopathy. Gout is a crystallopathy, and gout has to come into attacks. There should be signs of tophi if really. So if it's not a self-limiting disease, it is definitely not a gout, at least in the acute phase. And it doesn't cause persistent pains in the muscles and soft tissue. And all these pains may be basically, if you evaluate it, all this pain may be due to non-inflammatory pains, due to secondary to vitamin D deficiency, vitamin B12 deficiency, there may be disturbed sleep, all this may be fibromyalgia. And other thing I want to comment here basically is the uric acid level. Say, I not covered how the uric acid secretion happens to the kidney, but the secretion of the uric acid to the kidney is basically depending upon the number of secretory ion exchange channels, URAT1, URAT2, ABCB1, 2. So this varies from family to family. Suppose you may have a uric acid secretion power of say 100, your family may be running about 40 or 60. So initial phase during the early lifestyle adolescence, you may not have problem with uric acid secretion, but as we go on over the period of time, 50s and 60s, when you're as a natural tendency to age with the creatinine clearance going down, you may get your first attack in the 40s and 50s when your kidney function goes down in your old age. Other important thing, and so your uric acid may rise in old age slightly due to decreased GFR. other thing is uric acid level 7 to 8. The person with the higher, the patient with the higher muscle mass, the patient who is going to gymming, who has a high muscle mass, may have natural tendency of having uric acid level 7 to 8. So it doesn't mean they have hyperuricemia or they have got that may be natural level to them. Other may be like patient with high red meat diet, seafood diet may have a natural tendency to have the uric acid level in the higher level as compared to the pure vegetarian diet. So just looking at the uric acid level and treating with anti-hypouricemic drug may not be a right choice. The third scenario I think the people may confuse is osteoarthritis of the first joint. See, we see many people in 50s and 60s may have their valgus toes, in which they say there is a slight deformity of the base of the toes. And so again, the history is very important. When this is basically osteoarthritis of the first joint. This may happen because of overweight. The patient may be flat feet. The patient may have a altered dynamics of walking. All this thing may lead to faster wear and tear of the first joint, and it may look like it patient may have a gout. But when you see the X-ray clearly, before the X-ray, hallux rigidus is the excessive wear and tear of the joint. Will and the pain in osteoarthritis of the empty first mid hallux rigidus will be only when walking. There may be mild superficial redness due to trauma, the progressive deformity, but the deformity is very bony in character. While in gout, the gout will come in attack. The gout pain will be even at rest. There will be no relationship to walking, and the pain of gout reaches a peak within 4 to 6 hours. So it is very excruciating pain. It's just like your first MTP. And when you get the X-ray, we can get the clear idea to differentiate. When you want to differentiate osteoarthritis, the first MTP in a gout, you should look at the X-ray. The X-ray clearly shows this is wear and tear. There may be osteophyte here, decreased joint space here. But when look at the gout, there will be large erosion. So this is the third scenario when we should not label as osteoarthritis the first MTP as the gout. So I told you three clinical scenarios how the gout present. I told you three clinical scenario where gout shouldn't be looked at. So how do we investigate when we're suspecting a gout case? So in all, see, these are the four things you should always remember when you're trying to suspect a case of gout. So uh, you will always go through the SGPT. You will always look at the creatinine status for look for the how is the creatinine is raised or not. You always go through other thing. But the important thing I want you to remember the four things when you are trying to evaluate. The first thing is to check the uric acid level. So the patient comes and says, "Sir, my uric acid level is normal." Then also I'm getting the attack of gout. And why this happens? So I just have a single slide on this. So suppose your uric acid level was raised for last 4 to 5 years, and this uric acid was and your uric acid level was super saturated in your blood, and it has been deposited in the joints over the period of 4 to 5 years, and this is how it has smoothly deposited over the period of time. So the gout, this is the gout patient with static uric acid level. His uric acid remain between 7 to 8 and everything. Now what happens? There is a scenario when the patient has a binge drinking. When the patient takes a beer, there are a lot of purine content. The patient takes a red meat. The patient undergoes a chemotherapy, the acute rise in purine level. All those things which leads to hyperuricemia. There is supersaturation of purate pool, and this is a new uric acid crystal which is deposited here. When there is new uric acid crystal deposited here, and that happens when a uric acid crystal goes from 8 to 9. Okay, so this new formed uric acid crystal will lead to a new attack. This will be attacked by the macrophages, and this uric acid will expose to macrophages and get an acute attack of gout. This is normal scenario. Your uric acid level increased and you got an attack of gout. What happened in the second scenario? Now you had this static level of uric acid crystal deposited in your body, and now what happens? You start to have a hypouricemic drug. You start to have allopurinol. You start to have febuxostat and other things. And what happened? Suddenly your uric acid level from 6 to comes to 4. So what happened? Because your supersaturated pool has gone down, there is small amount of chunk of this uric acid deposited goes out from here, and the new area of uric acid crystal which are deposited get exposed, and this exposed area of uric acid now mounts a new inflammatory reaction through the macrophages, and you get an attack of gout. So this is a real reason why when you start a hyperuricemic therapy, you start to get a new attack of gout because new uric acid crystal get exposed. So I already explained why uric acid level may be normal. Almost 30 to 40% of the people may have a renal stone. renal stone, asymptomatic renal stone. We always take a history of renal stone, but every patient of gout, we are evaluating, we always get USG, KUB done to look for the uric acid stone because it may have two reasons. First, if the patient have uric acid stone, you have to start off the treatment right away, whether the uric acid level is normal or not with the history of uric acid, with the history of gout in the past. Another thing is when the patient have uric acid crystals, patient is basically over secretor here, and uh, adding a uricosuric drug may increase the chances of precipitation of more things. The third thing is whenever in doubt, if you have doubt whether this is gout or not, the knee joint and inflamed, aspirate and look for a send for uric acid crystal to be seen under compensator microscope. And the third thing is whenever you're looking at the patient of gout, we only don't focus on uric acid level. We have to always look gout as a metabolic disease. Every patient of gout may be strong family history of cardiac illness. Every patient of gout may have strong family history of stroke. Most of the gout patient may have hypertension for quite long. They may have dyslipidemia. So gout is a metabolic disease, is increases all the diseases which are associated with metabolic parameters. So I'll just focus few slides on management strategies. Now I have diagnosed the patient with gout and how should I approach it. So the management of gout, this relies on these three parts. The most important thing is the treatment of acute attack of gout and urate lowering therapy. These are two different pharmacological therapy of attack of gout. But I think the most important thing is the lifestyle modification. What are the lifestyle modification advices that is give you to the patient of gout? So we again come to my main slide, earlier slide, which I explained you. Every cell in the body has DNA and every cell has nucleic acid. So I will always advise the patient to decrease weight. Decreasing the weight will naturally decrease his uric acid level in the body. Definitely. Other thing, every cell in the body has ATP, ATPases, AMP, and GMP. So uric acid will definitely increase during surgery and physical. So the patient may have attack of gout during surgery. The patient may have attack of gout during fever. So basically, all this thing lead to increased body ATP demand and so purine and doubt. So I think purine rich diet, you should remember three things: alcohol, red meat, seafood, and the cold drink. These are four things. I think there is not much we can stop as far as vegetarian diet is concerned. There will be minor modification, but I think these are the four advices which you should always give to a patient: alcohol, red meat, seafood, and the cold drinks. And the other thing is when the uric acid is synthesized in the body, inborn error of metabolism. So we have to go only treatment for this part, but I think these are the three, four advices we go to the patient. 90% of hyperuricemia due to decreased renal secretion. So weight loss, diet modification, alcohol, red meat, seafood, and cold drink. See, we don't eat 100 grams of pulses and everything. So the dictum is yes, you may make some dietary modification, but no gross modification in the vegetarian diet is needed as far as things are concerned. So now patient have got an acute attack of gout. So now I have to decide. So first thing we have to definitely treat this acute attack of gout, and now I have to decide whether I should start on a urate lowering therapy or not. So management of acute attack of gout. So whenever I'm trying to manage a acute attack of gout, I should look the background of the patient. What are the comorbidities of the patient? Suppose the patient of gout may have deranged creatinine, which may lead to precipitation of gout. So I should always look whether the patient has deranged creatinine or not. In the patient of deranged creatinine, NSAIDs are contraindicated and a short course of steroid of the period of 6 to 10 days, like 10-15 milligram tapering 5 milligram every 2 to 3 days may really be a most important medication to subside acute attack of gout. The other thing is, suppose I am looking at patient doesn't have any comorbidities, then may I use either steroids or either NSAIDs or either colchicine. I prefer NSAIDs as such. We can use either of naproxen, etrocoxib, and methods. All three are equally effective. And if the patient doesn't get much relief in the steroid, may always add a small dose of steroid. Colchicine is also used during low dose during acute attack for initial few days, and it may be given as a background therapy when we initially start the acute hypouricemic lowering drugs. So now we have treated the acute attack of gout, and now I have to take a call. Now the patient is better, the attack has gone down 5 to 6 days of thing. Now the patient is feeling better. Now we have to decide whether we should start on urate lowering therapy or not. So what are the indications why I should start the patient of urate lowering therapy? So suppose our patient a uric acid level of 7 to 8, I want to make it 5 or 6. So I want this to prevent the recurrent attack of gout. I want the dissolution of the monosodium urate crystals. I want to prevent the progressive joint damage, and I want to prevent tophi formation. So all these things So the most important thing is you have to ask how many attacks the patient gets every year. So this is the ACR guideline, which clearly says that if the patient has more than 2 attacks a year, we have to start on uric lowering therapy. And suppose if the patient has only 1 attack a year, we may take a call whether we should start or not. We may not start. But suppose a patient gets the first attack of gout and you have to still, what are the indications that you should start this patient on the uric lowering therapy? So if the first attack of gout, you see whether patient has tophi deposition, you right away start patient on hypouricemic drug. Patient has serum uric acid level than 8. If the patient has renal stone, and if there is radiological evidence of that, in all this scenario, the first attack out, start the patient of hypouricemic drugs. So for the uric lowering therapy, I think we should first look at the target. So for the target, normal target which you see in day-to-day scenario when we have only recurrent attack, with target to lower the uric acid level below 6. And suppose we have tophi and other things, we try to target uric acid level below 5 milligram. We titrate the doses slowly. And normally what we start with is xanthine oxidase inhibitor. Either we use xanthine oxidase inhibitor or either we see uricosuric drugs. So I think xanthine oxidase is a preferable one because uric acid drugs are because most of them are under secretors. So mainly we stick to xanthine oxidase inhibitors, and here we try to xanthine to urate. So basically, we try to uh, uh, inhibit this enzyme xanthine oxidase through allopurinol and febuxostat. Both are almost equally effective. There are certain scenarios in which one is preferable in other. Allopurinol, you can start slowly titrating from 300 milligram and you can titrate up to 600 to 800 milligrams. And only thing problem with allopurinol is the severe skin reaction we gave in few patients. And other thing is febuxostat, which can be started with 40 milligram per day, and it can be titrated up to 120 milligrams. And the advantage is for febuxostat is it can be used with even the deranged creatinine, and it has less interaction. And when we look at the uricosuric drug, we normally don't use so often in clinical practice, but yes, they can be used. They are newer drugs like lesinopride, sufpirone, benzbromin, and probenecid, and these are the urcolytic drugs. Basically, urcolytic drugs are not much prevalent. Pegloticase is not available in India. Rasburicase is basically used in places when there is a tumor lysis syndrome, when there is a high uric acid level. They are not used in routine management of gout. And my few slide here on hyperuricemia as the manifestations are beyond gout. So when I look at a patient with hyperuricemia, the patient is getting acute attack of gout. When I look at the manifestation of hyperuricemia, I divide it into two parts: urate crystal deposition disorder or hyperuricemia, and not urate crystal deposition disorder. So one of them is gout, which I already discussed with you how the gout manifestation, other thing. Other urate manifestation of hyperuricemia is urate nephropathy, nephrolithiasis. And when you look at non-urate manifestation, we always look at cardiovascular diseases, hypertension, chronic kidney disease, insulin resistance, basically as a part of metabolic diseases. So yes, so there is a certain gray area in medicine which we look into whether we should put hyperuricemia or not. When, as far as crystal manifestations are concerned, asymptomatic hyperuricemia shouldn't be treated with urate lowering drugs. So, but when it comes to non-crystal manifestation of asymptomatic hyperuricemia, there's a lot of controversy. Few guidelines saying that yes, you can start on hyperuricemic drugs. Some guidelines saying we shouldn't start. Management of hyperuricemia in hypertension has shown some benefit, but in CKD, one of the meta analysis showed yes, this is effective. Other meta analysis so there is not effective. In cardiovascular disease, there is no clear-cut guideline. So coming to the take-home message, so I will label gout as the immune-mediated monosodium urate crystal associated inflammatory disorder. Hyperuricemia is essential but not sufficient for gout. Natural history of gout progresses from hyperuricemia to a recurrent attack of gout to chronic propitious gout. Clinically, acute inflammatory attack of gout is self-resolving when it is monoarthritic. Never miss a renal stone in a patient of gout. All hyperuricemia or not gout. Lifestyle modification is an integral part of treatment. Treatment of gout is long term. Okay, and gout is a metabolic disease with manifestation beyond the joint. Thank you.
Excellent talk, Dr. Sandeep. You have covered all the points, and These all, if you see, you will not find all this information in any textbook. This is all practical knowledge, and these are all scenarios which we face when we are in the OPD. So it's an excellent talk, and lots of confusion, I think, must be cleared after this. If anybody wants to ask something, you can put it in the chat box or unmute yourself and ask. Sandeep, you have cleared everything very, very well.
Ma'am, I have one question actually for sir.
Yes, please. Yes, please. Go ahead.
Thank you, sir, so very much for this wonderful presentation. Sir, regarding renal or CKD patients or patients having renal stone, you advise not to start with the uric acid lowering agents. Instead of that, I guess you have mentioned again short course of steroids. Sir, can you please enhance more regarding the treatment approach in these kind of patients?
Suppose a patient, so normally what happens in a CKD patient, there is decreased renal function. So
Yes.
we generally have hyperuricemia in patients of CKD. So so there are certain guidelines which says that patient should be on hyperuricemic drug. Then the certain guideline which says there is some benefit, the other says there is no benefit. Basically, they say that hyperuricemia in CKD patient leads to faster progression of CKD. So some nephrologists definitely add febuxostat to the treatment because febuxostat is safe as far as CKD is concerned as compared to the allopurinol. The first thing. So febuxostat is drug of choice for any kind of hyperuricemia in CKD patient. Other scenario is now the CKD patient have a uric acid level of 9 and above. So now we have to ask whether the patient, if the level is below 9, so we have to ask whether the patient has an acute attack of gout or not. Suppose the patient didn't had any acute attack of gout, but the patient still has renal stone. So in this scenario, we have to start the patient on hypouricemic drug like febuxostat. But suppose the patient is CKD patient has the uric acid level above 9 or above 10. In that scenario also, we have to start the patient on febuxostat drug. So this is because the important thing is, see, whenever a patient has hyperuricemia of 7 or 8, and when you start treating that hyperuricemia, so the number comes to have to treat around 23 to 24 patients over the period of 5 years to protect to prevent one attack of gout. Okay, so that is very non-practical when you see this in normal people. But when you see the same thing in CKD patient, okay, treating 5 patients of the period of 2 to 3 years or 4 years probably will prevent more attack of gout than treating a normal patient, a normal person with a hyperuricemia. So CKD patient, hyperuricemia, leave it to the nephrologist if they want to daily give it. Normally they start hypouricemic drug. CKD patient, renal stone, you have to start on hypouricemic drug. CKD patient, level 10 and above, start on hypouricemic, basically febuxostat. CKD patient, 8 around level, wait and watch. And suppose this patient get acute attack of gout, the CKD patient acute, your drug of choice, so will be steroids. So try to understand, we are trying to manage acute attack of gout and chronic hyperuricemia. For acute attack of gout, drug of choice is steroids. But for chronic hyperuricemia, the treatment will be febuxostat and other drugs.
Okay, sir. And one more
Yeah.
question, sir, regarding this new molecule topiroxostat, I guess.
Which
So,
one?
topiroxo, I guess, no? That one.
Topiroxate. Yes,
Yeah, yeah.
topiroxate.
So,
See,
is
it
the
has a mechanism of action, same scenario. There may be something that is much better, but I think right now the clinical experience in the Indian physicians and Indian people are less. So I'll wait still some time. Some people are already using it. We'll wait for a few more time just to start using it in clinical practice. But we're still sticking to febuxostat right now.
Okay, sir, last question regarding the perimenopausal women. You said that it is not always gout, right? So because of the
Yes,
estrogen clearance. So what should be
correct.
our approach if the patient is having polyarticular joint pain at that kind of period of time, I guess?
Correct. So you clearly told that the patient has polyarticular joint pain and swelling itself says that the patient doesn't have gout, to be very frank. So we should always ask the history. Is the patient having one joint at a time? The patient is having pain, swelling, superficial redness. The attack are very intermittent. The intermittent period of the joint, intermittent period between the attacks are symptom free. And if the patient gets polyarticular joint and swelling, I think you should first look for the other causes of polyarticular joint pain, and you should approach the patient as the patient having inflammatory kind of arthritis, the patient having non-inflammatory kind of arthritis. If the patient has non-inflammatory kind of arthritis, they maybe have number of other scenarios. When if you say the patient have polyarticular joint pain, they have pain, there is swelling, there's early morning stiffness more than 30 minutes in any of the joints. Okay, and then in that scenario, you should look into other kind of arthritis like rheumatoid arthritis, spondyloarthritis, other kind of connective tissue disease, and advise the blood report. Essentially, you can ask for raised inflammatory marker like ESR, CRP, RF factor, anti-CCP. I think approach is very different based on the history itself.
Right, sir. Thank you so much.
Yeah. Dr. Sandeep, one question in the chat box is how long do we give colchicine after an acute attack of gout?
See, the important thing is now, suppose today the patient has got third attack of gout, and today you decided that you should start him on hypouricemic drug. So the first thing, you manage the pain, okay, and then you start the colchicine. So on an average, there is no clear-cut guideline, but at least 3 to 6 months. So I start the so this is general part of my clinical practice. When the patient has a third attack, I continue colchicine at least for 2 weeks. Then I add febuxostat, a hypouricemic drug, because I just don't want the other attack of gout to be precipitated immediately. Okay, and I start the colchicine tablet, and I at least keep for 3 to 6 months before taking a call and stopping it. And I continue the febuxostat until that part and beyond.
Okay, thank you, Dr. Sandeep. And one more question is, I think this you have covered. If a patient comes to the OPD with uric acid 7 to 8, should we treat if no symptoms? So Dr. Sandeep has already said that if there are no symptoms, only a uric acid of 7 to 8 should not be treated. The other one question is treatment guidelines. Please explain in detail. But I think Dr. Sandeep, you have given the treatment guidelines in detail in few slides. This will be available for recording on YouTube. We will be sending the link. So if you have any specific question in that, please ask. So this is the slide which you can go over later. It will be all available on the MRA website and on YouTube. I think Dr. Sandeep, we can end the session.
Okay, ma'am. Thank you.
Yeah. Any other
Yeah,
questions? And yeah. Thank you so much, everybody, for attending, and thank you, Dr. Sandeep. Thank you for this
ma'am.
excellent
Thank you,
talk.
ma'am. Thank you, ma'am. Thank you, ma'am, for
Okay.
the opportunity. Thank you, ma'am. Yes, ma'am. Yeah.
Okay. Bye bye. Bye.